Welcome. Our intention is that by better understanding the dynamics of sexual violence, you will be expanding the level of care you provide. In this time, we'll explore foundational knowledge every healthcare professional should know about sexual violence, including what it is, how it shows up in patient care settings, and how we can respond with compassion, clarity, and confidence. Sexual violence is not about sex. The myth that sexual violence is about someone who just wants to have sex is rooted deeply in societal issues that shift blame onto survivors. In debunking this myth and many others, we must understand that sexual violence is ultimately not about sexual desire or interest, but is an intentional choice to dominate, to exert power and control over someone else, and to take away someone's agency and choice. As medical professionals, we often encounter survivors in vulnerable moments, and your trauma informed response can make all the difference. Together, we'll challenge common myths, examine the broad spectrum of sexual violence, and walk through practical trauma informed strategies you can apply in your everyday work. Sexual violence refers to any sexual act or attempt to obtain a sexual act through force, manipulation, coercion, or without consent. This can include unwanted touching, sexual harassment, rape, exploitation, sharing sexual photos without permission, and any other non consensual sexual behavior. It affects people of all ages, identities, backgrounds, and communities. When working with survivors, there are a few guiding principles to keep in mind. Sexual violence is never the survivor's fault. Believing survivors is the foundation of healing and trust. Every survivor's experience and their healing journey is unique to them. Holding these principles helps us create safer, more respectful, and more trauma informed healthcare environments. Sexual violence is more common than people realize. 1 in 3 women, 1 in 6 men, and nearly half of transgender and non binary individuals will experience sexual violence at some point in their lives. These numbers are even higher for people from marginalized communities, including Black, Indigenous, LGBTQ, and disabled individuals, due to the layered impacts of is and isms. That is, racism, ableism, homophobia, transphobia, and other systemic injustices. As healthcare professionals, understanding these disparities helps us create more inclusive, affirming, and trauma informed environments where all patients feel seen, heard, and safe. Myths and misconceptions about sexual violence are widespread and can create real harm for survivors. Let's address some common ones. In reality, survivors do not report right away. Most survivors never report, and when they do, it's often after a long period of time. Most perpetrators are not strangers, they are known, trusted individuals to their victims. And visible injuries may be absent altogether because many perpetrators use just enough manipulation, coercion, or pressure to gain control. By challenging these myths, we create space for trust, validation, and survivor centered care, essential foundations of trauma informed practice. Many survivors struggle with naming or making sense of what happened to them. Feelings of doubt, shame, or confusion are common, especially in a social culture that often minimizes abuse, spreads misinformation, and blames survivors. It's not our role to define someone else's experience, but as professionals, it's important that we recognize the many forms sexual violence can take and validate the wide range of feelings and responses survivors may have. To ground ourselves in a shared understanding, let's break down our operational definition of sexual violence, remembering that sexual violence occurs when someone uses force, manipulation, coercion, intimidation, or deception to engage another person in sexual activity without their consent. These tactics may not always be obvious. Survivors may describe situations involving pressure, emotional manipulation, or blurred boundaries. Recognizing these dynamics helps us respond with clarity, care, and advocacy, whether we're working with systems or supporting individuals. What does it look like when someone forces or manipulates another person into unwanted sexual activity? This could be any form of sexual activity that includes manipulation, intimidation, coercion, or pressure, or deception. Sexual violence includes a wide range of behaviors, some that are often recognized and others that are less commonly understood. Here are some examples to be aware of. Sexual harassment includes unwelcomed sexual advances, requests for sexual favors, and other verbal, visual, or physical conduct of a sexual nature, such as offensive jokes, sexual comments, or exposing one's breasts or genitals without consent. Sexual assault includes any sexual contact or behavior that occurs without explicit consent. This includes coercion, manipulation, or physical force used to engage someone in a sexual act against their will. The term rape is often used as a legal definition to specifically involve any form of sexual penetration, oral, anal, or vaginal, without consent. It can include being forced to penetrate someone else. Rape may be referred to in different ways. Stranger rape is committed by someone the survivor does not know. Acquaintance or date rape refers to rape committed by someone familiar to the survivor. Serial rape is often used to describe a series of rapes committed on separate occasions by the same perpetrator. Stranger rape and serial rape are frequently sensationalized forms of rape. Because of the gruesome nature of the assaults and the opportunity to prey on people's fears, both stranger and serial rape are frequently covered by the media and seen in popular TV shows. However, to many people's surprise, a vast majority of rapes are committed by someone who is known to the survivor. Child sexual abuse is a form of child abuse that includes sexual activity with a minor. This can include contact activity like rape, masturbation, kissing, and touching, as well as non contact activity like explicit sexual talk or showing pornography to children. It often involves a process known as grooming. Incest is sexual violence committed by an immediate family member or close relative. Sexual exploitation occurs when someone abuses their position of power or trust to gain sexual access, often for financial, social, or political benefit. Cyber exploitation includes sharing sexually explicit digital images or videos without consent, even if they were originally shared willingly. Reproductive coercion includes controlling a person's reproductive health decisions, such as pressuring them to become pregnant, sabotaging birth control, or forcing decisions around abortion or contraceptive. Stealthing, for example, refers to the non consensual removal of a condom during sex. These forms of violence may look different, but they all involve a violation of autonomy and consent. As healthcare professionals, recognizing these behaviors can help us respond more effectively and compassionately. People respond to trauma in many different ways, especially when the trauma involves sexual violence. There is not one right way to react. A survivor's response may be shaped by many factors, including their past experiences, exposure to systemic or historical trauma, emotional and physical health, the severity of the incident, and their own sense of safety or resilience. Some survivors may appear anxious, guarded, withdrawn, or hypervigilant. Others might seem disconnected, compliant, or unusually calm. Physical symptoms can include headaches, chronic pain, sleep disturbances, or gastrointestinal issues. These trauma responses can sometimes mirror symptoms of other medical or psychological conditions. That's why disclosure, not presentation, is the only way to truly confirm an incident or history of sexual violence. It's essential to approach all patients with compassion and curiosity, not judgment. Trauma informed care means understanding that what may look like resistance, noncompliance, or difficult behavior may in fact be a survival response to trauma. Medical settings can be especially difficult for survivors of sexual violence. Many people's survival brain and thus nervous system relate aspects of their medical appointments to the unpleasant, overwhelming, non consensual sensory experience of sexual victimization. Exams often involve physical touch, exposure, and a loss of control, experience that can feel triggering or unsafe for someone with a trauma history. Survivors may react in a variety of ways during appointments. Some may flinch at unexpected touch, disassociate, freeze, become tearful, or seem emotionally distant. Others may appear overly compliant or hesitant to ask questions. These are all valid trauma responses. Sensitive procedures, especially pelvic or invasive exams, require particular care. You can help reduce re-traumatization by offering choices whenever possible, explaining each step before you begin care, asking for consent throughout an interaction instead of just once, and allowing time for questions, emotional check-ins, and breaks. Remember, many survivors struggle to feel safe in their own bodies. Your approach, grounded in respect, consent, and clear communication, can help restore a sense of agency and dignity in the exam room. Every member of a healthcare team plays a critical role in creating a trauma informed environment. No matter your position, you have the power to help survivors feel safer, more supported, and more in control. Providers such as doctors, nurses, and midwives can slow the pace of care, explain each step clearly, obtain consent repeatedly, and give patients control whenever possible. Doulas and other birthing support professionals often serve as emotional anchors, especially during high stress moments like labor or exams. They can help voice patient preferences, offer grounding techniques, and advocate for trauma informed options that honor the survivor's autonomy. Medical assistants and support staff are often the first to notice red flags or early signs of distress. Their presence, tone, and responsiveness can help set the tone for a supportive visit. Receptionists and administrative staff can help foster a welcoming environment by using inclusive language, offering privacy when appropriate, and making patients feel seen and respected from the moment they arrive. Most importantly, make a habit of asking the people you see what they need and how they feel. You know your practices and the points of interaction that more regularly pose a challenge, so identify and anticipate increased advocacy response with survivors in mind. Talking about experiences of sexual violence, the how matters just as much as the what. Use gentle behavior based language that avoids assumptions or labels survivors may not use for themselves. For example, instead of asking, "Have you been raped?" try, "Have you ever felt uncomfortable or unsafe in a sexual situation?" Or, "Has anyone ever crossed a sexual boundary with you in a way that felt wrong or confusing?" If someone does share something with you, affirm them, express belief, and offer support without pressuring for more information. Be mindful of your tone, facial expressions, and body language. Survivors are highly attuned to nonverbal cues, especially in moments of vulnerability. Also, keep in mind that trauma can show up in unexpected ways like laughter, irritability, flat affect, or seeming too calm. These are normal reactions to trauma and may occur even if someone doesn't explicitly share that they've been victimized sexually. Finally, take care with escalation protocols. Actions like calling security, switching staff, or adding extra people to the room can feel threatening. Consider whether your safety steps are also trauma informed and survivor centered. Safety comes first when offering resources or referrals. Always ask yourself if it's safe for this person to take information with them. Handing someone a business card, flyer, or printed material may seem like a good idea, but if an abusive partner has access to their belongings, it could increase their risk. Consider offering alternative options. Maybe ask if they prefer a more discreet QR code or a digital link. You may be able to offer scheduling, a private follow up appointment, or invite them to take a photo of a resource if that feels safer to them. Some healthcare professionals may choose to have survivors use the phone in their office to call hotlines or access other resources. Let the survivor guide the pace. Respect their decisions without pressure, even if they're not ready for referrals today. Your supportive, non judgmental approach may lay the foundation for future help seeking. Above all, prioritize safety, dignity, and autonomy in every interaction. Sexual violence impacts more patients than you might realize, even if they never disclose their experiences. As a healthcare professional, your approach matters. Trauma informed care doesn't require knowing all the details, it requires small, intentional actions that communicate safety, respect, and belief. Let's review some things. Sexual violence is about power and control, not desire, sex, or sexual attraction. Myths and assumptions can cause harm. Let's replace them with compassion and knowledge. Trauma responses are varied and valid. Every team member has a role to play in creating a healing environment. Even without a disclosure, your care can offer validation, choice, and hope. Have your local and national resources ready. The statewide hotline for sexual violence is 1-855 Voices 4, and the national human trafficking hotline is 1-888 373 7888. Thank you for showing up for this conversation and for the survivors you support every day. You can learn about this and related topics at www.ncevsv.org. Click on the maternal health heading to access a wide variety of other recorded trainings, information about upcoming live trainings, customizable tools, and hundreds of other resources. This video was developed with support from a grant from the Michigan Department of Health and Human Services Maternal Mortality Surveillance Program. The opinions, findings, and conclusions or recommendations expressed in this publication, program, exhibition are those of the authors and do not necessarily reflect the view of the U.S. Department of Justice or the Michigan Department of Health and Human Services.